All right, hello everyone, and welcome to our forum, Hidden in Plain Sight, Identification and Healthcare Needs of Forced Laborers in the United States. My name is Daniel Bailey, and I am the chair of the Anti-Human Trafficking Committee at Doctors for Change. We are so glad that you have all decided to spend this evening with us learning about labor trafficking, an enormous but overlooked issue in our country. Our first speaker today, just to kick things off as soon as we can, is Dr. Melissa Torres. She is an assistant professor at the Baylor College of Medicine Menninger Department of Psychiatry and Behavioral Sciences and research lead for the Global Mental Health Division, which is comprised of the Anti-Human Trafficking Program and the Clinic for International Trauma Survivors. She previously served as the director of the Human Trafficking Research Portfolio and adjunct faculty at the University of Texas at Austin School of Social Work. She received her Master's of Social Work and PhD at the University of Houston Graduate College of Social Work, where she is adjunct faculty and co-founder of the college's Latin American Initiative, which provides summer learning abroad programs to Latin America in conjunction with local universities and NGOs. Dr. Torres served as the subject matter expert on the U.S. Department of Health and Human Services Healthcare Professionals Response to Human Trafficking Program, an initiative of President Obama's Federal Strategic Action Plan on Services for Victims. She currently serves as the human trafficking expert for various academic studies in the US and Latin America. So without further ado, I will give it over to Dr. Torres to give her presentation.
Thank you. Thanks so much for having me here and for hosting this important topic. I just want to make sure that you can see my screen. Are you able to see the presentation?
Perfect. Yes, we're able to see the presentation in full screen. Thank you.
Thank you. So I'll be discussing prioritizing labor trafficking as a human rights and public health issue. My focus over about 13, 14 years of research, direct service work and advocacy has focused on human trafficking, more specifically with the immigrant Latino population throughout the Americas. I have worked in sex trafficking of adults, children, foreign-born, domestic, but labor trafficking has been at the heart of a lot of the work that I do. And so I want to share research from different sites, including my own, and my experience on this. So one of the studies that I'll be discussing, trying to close this. Sorry about that. This out of the way. One of the studies I'll be mentioning here is actually one that we worked on when I was at the University of Texas. This is a statewide trafficking study, and you can see the graphic that we have there. Estimated 313,000 victims of trafficking any given day in the U.S. If you have heard of this, one of the numbers that gets thrown around a lot is the 79,000 number of minors and youth currently involved in sex trafficking in Texas, which is obviously an important matter that we need to address. However, the number 3 times as large is those that are victims of labor trafficking in Texas, which have not been as much of a priority recently. Labor trafficking globally is estimated to be 61 times more prevalent worldwide in various sectors. It's estimated that 3 out of every 1,000 people are in forced labor, in some sort of forced labor today. Of those that have been looked at, an estimated 55% are foreign adult victims, and this is foreign for, migrants in any country, 70% being men, 30% being women. Now, it's important to state that in many countries and under international definitions, sex trafficking is considered a form of labor trafficking because sex work is considered a form of labor services. So in some of those numbers, 12% were adult victims of sex trafficking, 10% were victims of both sex and labor. Again, in Texas, we estimate 234,000 laborers plus $600 million exploited annually through trafficking, labor trafficking. In our report, there was a small pilot study that we did, more specifically with construction workers and domestic servitude. And it was found and estimated based on the experience that they shared with us that out of the entire time that they're working, their entire career, 11% of that time is exploited or trafficked. So the legal definition in the US for labor trafficking includes different types of exploitation that can be done at severe levels: involuntary servitude, peonage or debt bondage, and slavery. I want to stress that this is one of the reasons that in particular, and this is my personal opinion, that I don't always use the term modern day slavery. Slavery is a form of labor trafficking and is not the only way that it happens. On that note, I won't speak against anyone who identifies as having been, who has that lived experience as having been in slavery or a slave. However, when we're talking about the greater narrative, we have to address all different types of exploitation and trafficking can happen and how the cases present. This affects identification in a lot of ways if it's not looked at as the most severe form that's happening, and it causes a lot of erasure and ignoring some of the people that are in the situation. So involuntary servitude would be being forced to work against your will. Peonage and debt bondage is paying off a debt that's constantly accumulating. You could never really actually pay it off. And slavery is more being held captive and against their will for the purposes of work. Why is it such a challenge to identify labor trafficking? Why is it such a challenge to actually understand it and how it happens? A lot of it has to do with policy. We are trying to look at this more as a human rights issue versus a business or a marketing or labor practices issue. But so many of the standards that are for labor are within different policies that could contradict what's actually written in the definitions of the TVPA. We always have to look at the labor standards before to see what they qualify as, unless it's a severe form of labor trafficking. And these are the types of gaps that we're trying to address in research. So under domestic labor protections, most fall under the US Department of Labor, such as the Fair Labor Standards Act, employment standards, OSHA, which is the organization that largely oversees construction type of work, Office of Workers' Compensation Programs, Labor Management Reporting and Disclosure Acts. For protection of foreign-born labor, most also fall under Department of Labor, State, and Homeland Security, or CIS. So this would be Migrant Seasonal Agricultural Worker Protection Act, work authorizations under visas that fall under the Immigration and Nationality Act. And the Department of State and International Labor Organization tend to look at trends that are happening worldwide. Something in particular that is of interest to me is where children fall into this and child labor trafficking. It's often ignored when we're talking about children as victims of human trafficking. We tend to focus on domestic minor sex trafficking. When it's children forced into labor, there's not as much attention to it. And honestly, there aren't a lot of protections for kids in these situations. Another thing is that policies change depending on sectors, which make kids more vulnerable in certain labor sectors than others. Again, the labor standards for children fall under the Fair Labor Standards Act. Many of these, like a lot of policies, are based on older regulations. A lot of it is based on parental consent, hours that are spent outside of school, and many are subject more to state laws and jurisdiction when you're talking about labor standards. All states have child labor laws and compulsory school attendance laws, and also establish minimum ages and conditions which youth may operate motor vehicles. And this is something that's also looked at by and reported to Wage and Hour Division. In terms of agriculture, this is where a lot of the laws do change for children, and agriculture is one of the most at-risk labor sectors in the US and worldwide. So child labor provisions in agriculture don't require that minors obtain permission, working papers, or work permits, although some states might. They limit working hours or times of day other than outside of school hours, do not limit working hours or times of day that kids can work outside other than the regulation of it when it's outside of school hours. They're not allowed to work during school hours legally. So I want to give an example of how labor trafficking can occur by using two of the most at-risk sectors here in the US, which are agriculture and construction. Another one of the highest top three sectors would be domestic servitude, which is a lot more difficult for us to address in terms of like policy and identification because it happens within homes. It's difficult to identify unless you're someone who has access to the home, or the victim and survivor can actually come out of the home and access assistance. So for general purposes and in relation, I just want to talk about agriculture and construction here. as examples. There are high rates of immigrant migrant workers and houseless workers in these labor sectors. We've done studies with worker centers in Houston, Austin. We're starting to also include Georgia and Seattle, looking in these populations and the risk that they have in different sectors. Agriculture and construction tend to be the most at risk, again, outside of domestic servitude, yet the ones that are hardest to reach out to and identify because of their working hours and working conditions and their lack of access to services that they might need. A lot of the workers have limited access to education, so children are able to be removed from school or limit school hours to work in agriculture. As far as discriminatory practices and rights violations, I've seen a lot of threats of unfair labor practices without fear of retribution, and I'll give an example of some of the retribution under policy there. Robberies occur a lot, threats of deportation or arrest. And one of the largest, or the first largest labor case in the US actually happened in an agriculture camp in Florida that was targeting houseless people to come offer them a space to live and work, and then giving them stimulants, drugs, and threatening to arrest them for having the stimulants and drugs. How this can affect health and how it can present, I won't go into too much because I know Dr. Gordon's going to speak about that, but just wanted to share my personal experience and what I've heard. I'll say that the most prevalent thing I've heard in my research, we talk about what kind of red flags can you see, what's out there. What I've heard of the most is ignore symptoms, diagnosis, and treatment of chronic illnesses, things that have already been there, that they've been struggling, they've been suffering for, but don't have the time, access, and really resources and money to actually seek help with. So then that causes a lot of the risk that they have for injury and health problems in workspaces. Just to give an idea of how agriculture and policy affects children and families in these spaces, here's just a few highlights from the policies. To give an idea, if you're 12 and 13 years old, you can be employed outside of school hours with written parental consent on a farm where the minor's parent or a person standing in place of the parents is also employed. This affects migrant families a lot. Mixed status, migrant doesn't necessarily mean immigrant, but immigrant, migrant, or mixed status families. Under the age of 12, you can be employed outside of school hours with parental consent on a farm where the employees are exempt from the federal minimum wage provisions. So I'll get into why I'm bringing up the minimum wage in a bit. Covered minors employees must be paid at least the statutory minimum wage for all hours worked unless otherwise exempt or employed under conditions. So there's a lot of policies here that have to be looked at to assess what kind of abuse, exploitation, or trafficking is happening, if it's actually happening. And this is why agriculture and children in particular are at highest risk for these situations that aren't necessarily considered illegal and are actually covered in these policies. What are the criminal sanctions if something is occurring and these labor standards aren't being kept by the employers? They're subject to a fine of no more than $10,000 or imprisonment for no more than 6 months, possibly both. If you're a large ag corporation, this isn't much to risk, and what you're winning from it by exploiting labor is actually more profitable. In construction work, just may surprise some people that 1/5 of construction workers are seriously injured, requiring medical attention, and workers' compensation insurance in Texas is not a requirement. 3/4 of Texas workers in construction aren't receiving any basic job safety training or equipment. This is federally offered through OSHA, and just so it's understood, OSHA does have to give notice if they're going to do a search of what's going on in an establishment. So I've heard a lot in the research that someone will go around telling anyone who's undocumented or that could speak up about anything not to show up on that day. Again, our pilot showed that 11% of a day laborer's time is spent in exploitative conditions, and the total time includes jobless days. So anytime that they could be working, it's 11% of the total time, not just the time they're actually working. Texas, since 2007, has continued to lead the nation in annual construction deaths at job sites. And so what are the compensation, safety, and health rights here? Texas Payday Law and Texas Minimum Wage Act is enforced by a Texas Workforce Commission. Only employees, no subcontractors qualify. And most agricultural workers and day laborers in construction areas are usually hired under a subcontractor, so they do not qualify. Employees are responsible for finding and correcting any safety and health problems. Again, OSHA requires the employers to provide personal protective equipment, but they can tell someone when they're actually going to be audited for this. Workers can request that OSHA inspect a site anonymously, though, without retribution. So we know that force, fraud, or coercion are critical to identifying human trafficking. In the situation of a labor case, this is where we really have to look at how these occur. And is it something that falls under these fair labor practices or labor standards or not? And how could we consider it trafficking? This comes from a report that we did in 2019 after we looked at calls that we had at a worker center in a year post-Harvey, and assessing by the kinds of calls that we got, looked at the range of exploitation. Under labor standards and fair labor practices, what we consider fair and legal, there's the range that goes from what is considered fair and legal through the force, fraud, coercion, and labor trafficking. In between those, what we largely see through worker centers and working largely with undocumented or houseless workers is wage theft, and this is the most common practice. However, even though the TVPA mentions people working without pay and be exploiting for profit, labor standards say something differently. That's considered wage theft, could be labor abuse, an abusive labor practice and exploitation, but not necessarily trafficking. So then that's where we have to go further than that to prove it as a more severe case to be considered labor trafficking. Discrimination also happens. Now, is it discrimination in terms of an abusive labor practice, or is it discrimination where it's being used as some sort of force, fraud, or coercion in a labor trafficking situation? For instance, telling people that you're going to call ICE and have them deported, or be involved in some kind of ICE raids or threatening to do so. Some barriers to identification. Again, I know Dr. Gordon's going to address some of this, but in looking at those that that might be barriers to the victim or the survivor that's presenting, the largest one is that they don't self-identify, especially in a labor situation where they're grateful to have some kind of work, where it could be abusive, but they don't necessarily see it as trafficking. They don't see that they're really doing anything against their will because they do want to have access to a job, and lack of awareness of what that victim status means. One thing I've heard so much is, that the word in Spanish, forzado and obligados, does come up, that they do feel forced and obligated, but that is not equated to being a victim of trafficking. Lack of knowledge of laws is something that's always held against them, that I hear all the time. And this is also for not just for the undocumented that are being threatened by, calling ICE or having them deported, telling them that they don't have any protections to labor laws here, which isn't true. It's also the houseless. And if you think about it, a study that we did currently with houseless day laborers in Austin, those that knew any kind of labor protections they had some kind of corporate job in the past and remembered from then. A lot of them who didn't have those jobs and had done more like manual labor in their work history weren't really aware of laws, but may have heard of OSHA or may have heard of Department of Labor wage and hour, but didn't really know what their protections were. Contractual obligations, especially if they feel or were told that they were sponsored by someone on a visa, or they would only get paid if they contracted and worked for a certain time, so they won't speak up if anything's happening during then. Language barriers, which goes both ways from victim and provider, and illiteracy. There's a lot of pushes for postering, especially with the seasonal migrant workers. It's mandatory that in agricultural campsites in particular, that they have postering and it's supposed to be in English and Spanish and a few other languages available. A study done looking if whether that was actually healthy didn't find a lot of posters on site, or saw that it wasn't in the language in Spanish or other languages needed, or there was a high illiteracy rate with the workers. On the provider side, there's a lot of misclassification, and especially with labor trafficking. This looks like, something that's the victim's fault because they didn't say something, or, this isn't a trafficking situation, it's just unfair practices, or they're working in a high risk situation, and labor isn't looked at, or rights in labor sites aren't really looked at as a public health issue. Lack of cultural humility, again, going to the judging of populations coming in, or really not understanding how to best serve them. Re-traumatization, a lot of times we hear about this within sex trafficking, but in labor trafficking as well. If they feel it's their fault as a worker who didn't keep their part, then they're gonna, internalize that as well and not speak up about what's going on. If they're grateful to have the job, then they're going to internalize what they're going through and say that it's their fault for, not doing what they're supposed to do. Unaware of indicators for labor trafficking, again, language barriers, and criminalization and non-inclusive site protocols. So, a lot of times being spoken down to if they think, even if you're not undocumented, if you're just an immigrant or English is not your first language, and being spoken to as though you are undocumented, assumed to be undocumented. If you're houseless, assumed to be on drugs, or, a thief, these kinds of attitudes towards them. And also, something that I've heard a lot, which I see at hospitals, is, security guards at the front that a lot of people will see or misinterpret as police, and be scared to enter, thinking that they could, have that criminalized identity put on them, and being threatened with being deported, or, searched, or whatever. So that's my experience in working with labor trafficking, and some of the needs that are there. Here's my contact information if anyone has any questions. Thank you.
Thank you so much, Dr. Torres. We'll go ahead and move on to our next speaker, which I'm excited to introduce, Dr. Mollie Gordon. She is an associate professor at Baylor College of Medicine's Menninger Department of Psychology, and the medical director of Baylor College of Medicine's Anti-Human Trafficking Program. She is also the associate director of the Inpatient Psychiatry Unit at Bentall Hospital, and the co-founder of the Division of Global Mental Health. Her research focuses on clinical best practices for mental health of human trafficking survivors and capacity building in the space of global mental health. Her more recent research in the field of human trafficking and mental illness has resulted in numerous publications in the field, the establishment as well of the first fellowship in the mental health treatment of human trafficking patients in an academic medical center. And she is also the founding member of the Texas Medical Center Human Trafficking Healthcare Consortium. She's the co-chair of AMWA PATH and is passionate about the interface of human trafficking and mental health. So, Dr. Gordon, please take it away.
Thank you. And thank you, Melissa, for your very informative talk. I learned something too, which I always think is a good start. So some of the things that Melissa has, or Dr. Torres has touched on that I'm going to follow up on as it relates to healthcare was her mention of the TVPA Act. The TVPA Act is the Trafficking Violence Protection Act. It was passed about 20 years ago now. And the focus is very much on prosecution. It was passed by the federal government to address issues like prevention, to increase prevention measures. And that includes things like research, education trainings, and authorization for the US government to assist other countries in their prevention efforts and creation of legislation internationally. It also focuses on issues related to protection. And what that means is that the US government put forth effort to protect trafficked foreign national victims, including direct assistance and services, and creation of non-immigrant status for those willing to cooperate with law enforcement, passing through things like T visas and continued presence. And I think we'll probably get into more details about what that means on our panel. And then the third arm is the prosecution arm, which is to strengthen the government's efforts to prosecute traffickers and expansion of definitions. I just got like really big. Sorry, I don't know if everybody else sees me really big suddenly. Okay, and so what that means is, like Dr. Torres mentioned, that there needs to be an act and a means and a purpose, which means from a prosecution standpoint, there needs to be some form of entry into exploitation, which is a human rights issue, through the means of force, fraud, and coercion. And for the purpose of financial exploitation, in this case, labor trafficking. We're not going to talk about this spectrum right here. We're just going to focus on Dr. Torres' slide of that red arrow, just the trafficking arm. And force, fraud, and coercion is something that's very tricky. So from a prosecution standpoint, it's very difficult to prove that an adult was forced, frauded, or coerced. When we're talking about issues with minors, that's a little bit more straightforward because minors are more vulnerable. But when we're talking about force, fraud, and coercion, those need to be proved for prosecution to occur. Otherwise, it moves sort of down the spectrum, like what Dr. Torres was talking about, into areas of labor abuse, wage theft, poor labor practices. And what we're looking at is trying to prove labor trafficking. And so because of those difficulties, a lot of persons who are victims of labor trafficking go unnoticed. The prosecution takes many years. Sometimes they have to testify against their trafficker, which can be very psychologically distressing. And coercion presents itself in lots of different ways. And both the coercive tactics themselves, along with some other tactics along with some other issues we're going to talk about later, can cause healthcare impacts that we are interested in treating and addressing. So methods of coercion that have been described by Susie Baldwin's work. She wrote a really nice paper that's been cited numerous times in the literature using the Biederman model of the Biederman framework of coercion. And Biederman was a sociologist who studied Korean prisoners, American prisoners of war in Korea who falsely testified to crimes they did not commit. And what happened is when Dr. Baldwin and her team interviewed labor trafficked persons, or trafficking in general, many of whom, and the majority of whom in the study were labor trafficked, she found that the same methods of coercion, psychological coercion, which were used in prisoners of war, was actually used in labor trafficking. And those 8 very well documented forms of coercion include things like isolation. So separating the trafficked person from their support network. So somebody is in a foreign country, or somebody is separated from their family and their loved ones. Somebody is living where they work. Somebody is in a home where they can't leave or has no access to reach out through technology, phones, computers, etc. Somebody's on a farm where they don't have access to roads or buses. So isolation is may not be something we consider as healthcare providers, but is actually a form of psychological coercion. Manipulation of perception, developing a relationship with the victim of labor trafficking who feels like they're their only source of information, whether they're, what they need to do, when they need to do it, the consequences of which will occur, whether psychologically, physically, or legally, which will occur if they don't abide by their employer's recommendations. Induced debility and exhaustion. So this means, it's pretty straightforward. So this means literally working people to the point of exhaustion, sleep deprivation, food deprivation, extremely unsafe or demanding working environments, including toxic exposures, like Dr. Torres mentioned, unsafe work environments, non-regulated work environments, threats, and we'll talk a little bit about what those can be. Those can be both psychological threats, physical threats, sexual threats, or forced drug use threats. The occasional indulgence to create a trauma bond. Often traffickers will create relationships with their victims so that they will give intermittent reward. And that same form of intermittent reward is the same form of intermittent reward that we think of when we think about things like gambling. So there may be an indulgence that comes out of nowhere and is unexpected. And so the trafficked person may be more likely to attach to their perpetrator, thinking that those rewards will come, whether they're financial, food, housing, freedom. There's all sorts of different forms of reward. Demonstrating omnipotence, which is sort of this holistic presence, that they're the only person who can make decisions in that person's life, and the trafficked person will then feel that resistance to their trafficker is futile. Degradation, which can be both psychological and physical, and then the enforcement of trivial demands. So having the trafficked person do things that are outside their working requirements, or that the trafficker could do themselves. And so those sort of psychological coercive tactics have psychological impacts. And so we're going to talk a little bit about what those are and how they present to healthcare settings. So that's one way in which the trafficking experience can be distressing to the victim. There's also, like Dr. Torres mentioned, healthcare outcomes, both psychiatric and physical, that can occur by negligence. So when we think about healthcare as a public health response, which is how we're looking at this, and I should actually back up. I just kind of skipped over this part. One of the issues with the prosecution arm is that those elements of force, fraud, and coercion must be present, and there must be enough substantial evidence to prosecute a trafficker. And if that is not found, then that becomes very difficult. From a healthcare perspective, we know that trafficked persons seek healthcare. In some studies, some would cite 60 to 88% in some smaller studies, but we know that they have healthcare needs and that they do reach out to healthcare services. We know they reach out in Dr. McKinney Chisholm's work, healthcare providers who most often see trafficked persons, in addition to mental health providers, include emergency room providers, urgent care providers, obstetricians and gynecologists, and adolescent health doctors, and actually dentists. But I think of urgent care as really kind of the hubbub of where trafficked persons get their care. And so sort of back to this conversation about where harm occurs and how that impacts health. If we're thinking about healthcare as a harm reduction model, labor trafficked persons can have harm beget them without psychological coercion necessarily, without physical violence, but by neglect of chronic medical conditions such as cardiac conditions, diabetes, wounds, injuries, toxic exposures, etc. The labor trafficked patient may endure physical harm as a form of coercion. So there's this element of psychological coercion, and there's also this element of physical and sexual coercion. So physical harm may be using of a weapon to injure someone who doesn't abide by their rules and recommendations, and that goes from everything from knives, guns, beatings, physical assaults, cuts, burns, etc. There's also physical harm that can occur on site because of the lack of oversight, the lack of OSHA, the lack of regulatory equipment. So things like falls, head injuries, pesticide and toxic exposures, heat stroke, sunstroke. So this physical harm can be either by their trafficker or by their work. And so these are things to consider when we think of exposure to risk of the trafficked person. There's this, in the prosecution world and in the medical literature, unfortunately, there's this world of like, you're either labor trafficked or you're either sex trafficked. And the reason that's very difficult is because that's where things like services differentiate. That's where things like funding differentiate. That's where things like research differentiate. But the truth is that sexual violence actually occurs on a spectrum of labor trafficking. So a person may be labor trafficked on an agricultural farm or in a domestic environment, but they may also be sex trafficked too as part of that experience. That may not be their primary form of exploitation, but that may occur concurrently. Sexual violence may be used as a way to exert control, either by other persons who they work with or work for, or by their trafficker themselves. And then other forms of harm include things like drug use. So Dr. Torres commented on this quite nicely when she mentioned forced drug abuse for improved outcomes. So why would you give somebody drugs? Well, hopefully they'll be awake longer, and then they'll work more effectively or efficiently, and then there'll be a financial remuneration that occurs from that. Also, drug withholding can be used as a psychological tactic. So you may give somebody alcohol or sedative hypnotics, and then or opiates, and then withdraw those drugs as a form of control, and that can have a lot of physical and psychological harm. So coercion, which we discussed, these psychological tactics can cause adverse health outcomes. Neglect and lack of access to healthcare can cause adverse health outcomes. Physical harm that occurs by the hands of the trafficker or their environment that's unsafe can cause health outcomes, sexual violence, and drug use. So I like to say it is not good for your health to be a trafficked person or to have your rights violated. It may seem obvious, but they are quite significant what sort of health outcomes those are. I'm just going to scroll down, make sure I've addressed all these issues in my notes. In the formal definition, we talk about recruitment, harboring, transportation, provision, and obtaining of a person for labor services to the use of force, fraud, or coercion that we touched on for the purposes of servitude, peonage, debt bondage, and slavery. And labor services, when they are a commodity, can be an area of trafficking. So in addition to agriculture and the service industry, in addition to agriculture and private homes, the service industry, massage parlors and spas, cantinas, entertainment clubs, bars, streets and panhandling, we've seen forms of forced labor, and even places that we think may be more regulated than others, such as factories, can be areas of labor trafficking. I'm not going to talk about this. I think Dr. Torres did, about labor exploitation being a continuum, the extreme version of which is trafficking. There are intersections to consider that I've touched on, sexual assault or sex work that may occur concurrentently with labor trafficking, violence, wage theft as sort of an introduction into or concurrent with trafficking. So those can occur simultaneously. They don't have to be mutually exclusive. And then this concept of smuggling, which is a crime against a border, where trafficking is a crime against a person. Sometimes trafficked persons are smuggled, sometimes they are not. Sometimes smuggled persons are trafficked, sometimes smuggled persons are not. So illegal activities can occur together, but they are also mutually exclusive. So there is an area of overlap to consider, but they are different crimes. And so what we're talking about is a crime against a person, whereas smuggling is a crime against an international border. So some of the psychological coercive tactics we discussed can have significant adverse health outcomes. This includes affective disorders like mood disorders, symptoms of PTSD and complex PTSD, adjustment disorders whereby the person has an acute stress symptoms. Self-harming can occur either as a way of self-regulating or as a way to escape their trafficker. So sometimes patients will self-injure as a way to either avoid work or to seek emergency help. Some of that self-harm may be injurious. Some of that self-harm may be with intent for suicide. Substance abuse, either by force or substance use by choice with subsequent addiction and withdrawal is very often seen in trafficked persons. We've discussed route of entry into care, and so providers across disciplines need to be aware that trafficked persons can present to them either as children or as adults. We see a lot of physical health sequelae of trafficked persons. This study comes from the British literature from NHS. So sort of from head to toe, we can see constitutional symptoms, fatigue, weight loss, loss of appetite. And again, this occurs as a result of psychological experiences that the trafficked person has, neglect of chronic medical conditions, or the physical harm by the trafficker, or their unsafe work experiences. Neurologic symptoms are significantly common. Anywhere between 20 and 58% of trafficked persons describe headaches, dizzy spells, memory problems, fainting. GI symptoms are present, but a little bit less common, including stomach pain, diarrheal illness, infectious illnesses. Cardiovascular symptoms such as difficulty breathing and cardiovascular chest pain can present either as a psychiatric symptom and manifestation of anxiety and panic, or due to neglect of chronic medical conditions, or due to exertion and environments, not being in the heat, not having access to water, and as well as neglect of chronic, what I talked about, or as well as from physical harms and injuries. Musculoskeletal symptoms are probably similarly as common as neurologic symptoms, including chronic back pain and dental and face pain, ear and eye pain, either again from exposures, injuries, or unsafe environments. And then dermatologic symptoms are actually quite present, including things like unhealed wounds, rashes from poor living environments, and then infectious illnesses. Medical doctors are uniquely suited, not necessarily just psychiatrists, but medical doctors who treat medical conditions are particularly well suited to treat and to respond to the needs of trafficked persons. Not all fields of medicine have a policy on trafficked persons. We wrote a paper about which ones do, and we're hoping that whatever field you go into, whether it's things like ophthalmology, physical medicine, and rehabilitation, that that one of the things that Doctors for Change can do is to advocate for policies in medical organizations on trafficking as a form of abuse. So everything from electrodiagnostic medicine to spinal medicine, folks who see patients in emergency situations and in subspecialty care, in addition to mental health, are likely to come across a trafficked person in their practice. Our program seeks to create a formal public health response to trafficking, and that can be very comprehensive and very broad. And so to do this, that includes things like education, research, clinical care, and advocacy. So when we talk about education, that includes things like primary prevention, knowing your rights. So that's a very first step. One of the things Dr. Torres discussed was, barriers to care and barriers to identification. So if a trafficked person doesn't know they're being trafficked, they may not seek help either from a provider or from law enforcement. And so primary prevention includes outreach, it includes preventing trafficking and the vulnerabilities of trafficking from occurring before the person is exploited. There are both individual and community, what we call push factors, that increase the risk of a person being trafficked. And then addressing the healthcare needs of trafficked persons by educating the providers. So sometimes the barrier to care is on the patient side. More often, the barrier to care is on the provider side. And so educating healthcare providers across disciplines is something that we do. It is something that the state of Texas has been very vocal about. So another way that Doctors for Change can continue to stay involved in policy is to continue to encourage folks like the American Hospital Association and the Texas Department of Health and Human Services to require training for trafficked persons. Currently, Senate Bill 2059 does this. So all licensed healthcare professionals who are renewing their license and providing direct services are required to take an hour of trafficking annually. And so we do a lot of outreach, and then with a lot of education, and then once providers are educated, they can identify trafficked persons in the healthcare setting and then respond to them. And we'll talk a little bit about that shortly. Our clinical care is provided in a consult liaison model. What that means is that having educated healthcare providers, they can then screen for trafficked persons, both labor and sex trafficking in their healthcare settings, and then page our trafficking team, which includes an immediate response by our clinical case manager, Katie, who's going to be on the panel with us shortly, as well as our fellow who can evaluate that person for trafficking and assess their acute medical and mental health needs, and then come up with a treatment plan that triages the patient and addresses their mental health and social needs. A lot of the work we do is very new. The public health response to trafficking has only been around for about 15 years. And so we do seek to contribute to the literature across disciplines. So we work with physiatrists, plastic surgeons, emergency doctors, pediatricians, adolescent health doctors. Even though we're mental health providers, we work on an interdisciplinary team and collaborate extensively across disciplines and across fields. And then a lot of the work we do is related to advocacy through programs like Doctors for Change at the state, local, federal, and international level. We have been less successful in identifying labor trafficked persons in our program, and so we are working to fill those gaps. We think some of that is that some of the reasons behind that is that a lot of the education really does focus on sex trafficking, and we seek to fill those gaps by reaching healthcare providers to address labor trafficking and not just sex trafficking. And again, a lot of the literature focuses on sex trafficking. And as Dr. Torres mentioned, the majority of the trafficking in the state of Texas and international really is labor trafficking, and is more likely to go to be missed by healthcare providers. I think I'm going to skip that. Hold on. So persons can enter. I know we're short on time, so I'm going to try to be quick. I think I'm almost done. Persons can enter exploitation through relationships with their traffickers, where they trust somebody who then turns and exploits them, through false advertisements and job offers that turn out to be something that they're not. There may be substance use, intimate partner relationships that are then exploited, and online platforms that are used to turn and take advantage of vulnerable persons. We talked a little bit about the coercive tactics that allow persons to do that. From a provider standpoint, there really are 3 areas where providers can address trafficking. They can recognize the symptoms of trafficking in their history, in their environment, in their physical and in their psychological presentations. So as an example, converging vulnerabilities of being exploited may present in a patient's social history, a history that may look scripted or rehearsed, a history that is different among providers. So then either the story seems like unusually rigid or unusually inconsistent, where they may tell different persons on the team different things. Prior history of exploitation, traumas, and victimization, and other circumstances where things like labor trafficking may not be unusual to them. They may have been mistreated by others over their lifetime. Differences in personal information, birth dates, multiple MRNs. Dr. Torres thankfully addressed the barriers to identification, so I'm going to skip that. Other things that providers can do to recognize a trafficked person in a clinical setting includes environmental cues, such as suspicious accompaniments. Somebody who, wants to interpret for the patient, wants to stay present in the room, may hold that person's IDs and personal information. And there may be obvious safety concerns, where there was an incident recently where somebody who was trafficking somebody the trafficker themselves was in the hospital creating a ruckus, not the patient. And so the patient may present to the provider with physical complaints that include things like recent physical assaults, as I mentioned, sexual violence, significant neglect of medical conditions, malnutrition, or maltreatment, injuries in various stages of healing, which is something we often think of when we think of child abuse, but can occur in adult abuse. Any forms of indication of ownership, and then any sort of those chronic medical, or those complaints that we discussed, like neurologic conditions, cardiovascular conditions, constitutional symptoms, or GI symptoms, where a patient presents to emergency setting with that differential, then with those complaints, then that trauma and abuse should be on your differential. Psychological symptoms can present in all sorts of manners. Most often, it's issues of fear, anxiety, guardedness, or thoughts of anxiety, depression, thoughts of depression, withdrawal, and self-harm. Psychotic symptoms are much less present. So if somebody presents with converging histories, psychological presentations, and physical exams, then those are things that we should, those are times when we should consider labor trafficking. The Polaris Project has a really nice set of questions that providers can ask for screening. None of these are validated in healthcare settings, and Dr. Torres hopefully will be fixing that for us with some of her upcoming research. So for some examples of questions, asking things like, sometimes people may make efforts to repay a person who provided them with transportation or a place to stay or money or something else they needed. Do you owe somebody money and have difficulty paying off that debt? Sometimes people live where they work, or where the person in charge tells them where to live and they're not allowed to live elsewhere, or their movements are restricted. Does that happen to you? Sometimes people are not allowed to keep their own identification and travel documents. Has that ever happened to you? And so the trauma-informed model of care that Dr. Torres mentioned is based on SAMHSA's key principles. So providers who suspect trafficking can respond to trafficking in their healthcare settings. They're not necessarily looking for a disclosure. So unlike the prosecutors and the TVPA, where they're looking for a response that is going to confirm the presence of trafficking, healthcare providers are just looking for those red flags or suspicions of trafficking so that they can respond in a trauma-informed manner. And so some of those principles include things like keeping the patient and the provider safe, developing a sense of trustworthiness and transparency between the patient and the provider, offering peer support, collaboration between the provider and the patient, empowering the patient's voice and choices, and then cultural humility and gender sensitivity issues as they present in healthcare settings. So there are a lot of ways that providers can refer to resources both locally and then here in, and also on the federal level. We'll talk a little bit about that on the panel. If a patient is seen in an emergency situation and they're in the Harris Health program, they're welcome to page our team. There are also community partners and community case managers that Katie and we can talk about further. Task forces at the prosecution level, faith-based responses, substance abuse treatment and rehabs, and residential treatment programs that can help persons. Unfortunately, there's a lot less available for men and a lot less available in the city for victims of labor trafficking. We're hoping that changes, and we're working towards coming up with solutions that meet the needs of these patients and fill these gaps that are not gender or trafficking specific. I think that's it for now. I think some of these resources we'll talk about, on the panel. So I'm going to stop because of time. I'm probably very over time, despite my talking fast, and then give the screen back to Daniel for the panel.
All right, thank you so much, Dr. Gordon. We're going to go ahead and start our panel event now. So if all of my panelists and speakers could turn back on your cameras, we can get started with introductions. While we're going through some brief introductions, I would encourage all of our attendees to start sending in questions through the chat box or the question tab on your right. So please go ahead and start sending some questions in while we introduce each person. I'm going to call on each of you to just give a brief overview of who you are and what your work is in labor trafficking. So we'll go ahead and start with Zenobia Lai.
Good evening. This is Zenobia Lai. I am the Executive Director of the Houston Immigration Legal Services Collaborative. We are a collaborative of 32 organizations that include immigration legal service, social service providers, organizers, and law school clinics. So our work is to advocate for immigrant inclusion, equity, and justice. So we incubate programs to meet community needs. So what is relevant to this discussion is we have immigrant rights hotline where people can call in to access legal services and social service referrals. So if in your work you encounter a victim of human trafficking, that's the resource that you can refer to them so that they can be connected up with legal services and social services. We also have a working crime victims working group that made up of representatives from legal services provider in Houston area to tackle the issue of getting the government to cooperate to support the immigrant victims application for immigration relief. So one of the things that we focus on would be the immigration aspect of the TVPA. The T visa was created under TVPA passed in 2000 to provide a pathway for victims of human trafficking to access immigration protection. So what it does is that a person will be eligible for T visa if he or she is a victim of severe form of human trafficking. Labor trafficking being a very common form of trafficking that in the cases that I handle in my previous jobs. There's a requirement that they cooperate with the law enforcement in the investigation or prosecution. Prosecution doesn't have to happen, but investigation would have to happen. For example, you can call the police. It could be a state or federal law enforcement agency. And if the victim is under 18 years old, they don't have to cooperate because of their age. And they also have to establish that their physical presence in the United States is on account of the trafficking. That is a trafficking act from them to the United States. And that if they were to be deported back to their home country, they would suffer extreme hardship. Financial hardship alone cannot make up extreme hardship. So one of the often that we rely on would be whether if they were deported back to the home country, they would fall victim again to be a victim of human trafficking, especially for victims that have a lot of debt issue. Right? What is the benefit for a T visa? If approved for T visa, the individual would have immigration status for 3 years under the T visa, and they are authorized to legally work with employment authorization. And after 3 years, they can apply for green card to have lawful permanent resident status. They can also cover their family members, such as their spouse and the children under 21 years old. And if the victim is under 18 years old, they can include the parents and the siblings as a derivative under the T visa program. So they will be eligible for public benefits if they are otherwise income eligible. One of the my work when I was in Washington, D.C., which happens to be the hub of embassies and also international NGO, we encounter a lot of victims of human trafficking in the labor side. For example, there are a lot of domestic workers that are domestic servants in these embassy households and also in the international NGO households. And those are, oftentimes very difficult to reach. And they rely on neighbors or just caring people in the vicinity that kind of help connect them with the outside world. But one case I want to kind of briefly discuss is I worked with a group of about 4 dozen Filipino teachers. They were highly trained special ed teachers that they were recruited to come to the United States. So they pay a lot of money for the process, which amount to about 4 years of their salary to pay for the fees to be able to traffic to the United States. So they were promised special ed positions in public school districts. But when they arrived to the United States, there were actually no jobs existed for them. Right? So what is involved in this process is there's a labor recruiter in the home country that actually have a business. The business is to recruit labor. And there's an American immigration lawyer actually based in Houston that handle all the immigration work. And then administrators from various public school districts that pretend or act as the employer to provide a certification for them to come. So everything is legit on the immigration side, paper-wise. So they came in under a work visa, except that the job never existed. So as soon as they arrive, so the trafficker would arrange, the recruiter would arrange for them to live in certain housing. It would be a 1-bedroom apartment for like a dozen of them, has no beds, they all sleep on the floor. And they have no access to food. Usually it could be like in a rural area where they have no transportation. And then very soon after they arrive, the recruiter will shop them around for jobs in daycare center. So a lot of them were placed in the daycare centers that the recruiters have connection to. And they were paid minimum wage, and they immediately lost their immigration status when the original employer petition for them was not the employer. So they came to us. I think they were like 2 of them came to us to our regular intake process in Washington, D.C. And initially, they wanted to go after the recruiter as an employment case. And it's only through more interview that we realized that this is actually not an employment case, it's a labor trafficking case. And through these 2 individuals, we reach out to about 100 of them and use a church facility to kind of get them together to discuss what immigration protection they're eligible for and kind of shepherd them through the process. So this was 2013, about 2 years ago, at least the first of the Filipino teachers that I helped told me that they got the green card. So I guess that would be the first of many of them that were approved T visa getting green cards. And very soon they could also be eligible for citizens. Because the previous 2 speakers have talked about a lot of the resources, so I'm not going to repeat it. But a lot of times victims of human trafficking are hidden in plain sight. It could be your neighbor, right? And this is a person that somehow didn't have the freedom to leave the house as they please. They may not have the documents. They have no money because the employer didn't pay them. So there are a lot of telltale signs that as medical providers, you may be able to kind of help connect them with services that could help them. And threat of deportation is always something that they're hold over their head by the trafficker or labor recruiter, and letting them know that there's actually immigration protection for them is critical for them to be able to step out and seek help. And I'll wait for other panelists to present.
All right, thank you. And then we'll move on to Katie, if you could introduce yourself.
Hi, good evening. My name is Katie Robichaux. I'm the clinical social worker for the Baylor College of Medicine Anti-Trafficking Program. This year, I guess, will be my 5th year providing direct services to victim survivors of trafficking, regardless of age, nationality, or type of trafficking. So previously, I was at a refugee resettlement agency, and now I'm at a hospital. So the cases and the clients and patients are quite different. So anything I can contribute, I will try.
Thank you. And Rachel?
Hi, good evening. My name is Rachel, and I have been in the field for about 10 years, working directly assisting victims and survivors of all forms of human trafficking. In those 10 years, I mainly been, like Katie, working under a refugee resettlement agency, Houston and in Austin. In the past 5 years, I've been in Austin, but working statewide, helping start programs such as DOJ-funded programs, like in the Valley, in Amarillo, North Texas, Houston, Austin. And the past year, I've had a shift of careers and worked in more so the prosecution section with the Attorney General's office under our kind of fairly new civil statute that helps prosecute trafficking in the civil way. It was great to hear Gordon and Dr. Torres speak about just how difficult it is, this criminal world and public health world, how trafficking is usually seen as a criminal justice issue, but I've been trying to preach to the choir and saying, no, it's a public health issue, because we know how there's a lack of assistance to victims if their case isn't investigated or prosecuted, such as crime victims compensation that won't qualify for any restitution, or even immigration. It's difficult to prove a T visa without that reporting with law enforcement. So with working with the OAG's office, it's been great to see these different types of labor cases. It's been unique, and seeing just like Zenobia spoke about daycare teachers, some other venues as well that I haven't had much experience, but was exposed to these church cult labor trafficking cases. That really happens quite a bit in Texas, which is something I wasn't aware of. But being within the state, working under the state as a civil investigator, we help push CT, continued presence. That also is like the TV sub, but it's only provided by law enforcement if a case is going through investigation and trial. I think one big thing that for services is once a victim survivor does get this TVC or CP, they are rewarded a certification letter to get benefits from DHHS, and that will provide them with Medicaid and food stamps and assistance to help them recover after a post-victimization. And now I am no longer working with the OAG, just to clarify. Thankfully, going back to Houston and working with another state agency, TABC, and continuing working with labor trafficking victims, hopefully more so in cantinas, strip clubs, or anywhere where alcohol is being sold. So, thank you for having me.
All right, thank you. And then lastly, we have Yuri Guerrero, who is a labor trafficking survivor, advocate, and speaker. We are very privileged to have her tonight. When you introduce yourself, I want you to try to give us a summary of, what you went through and how you got recruited into labor trafficking and how you escaped. So take it away.
Okay, thank you so much. Good evening to everybody. I want to say thank you to Dr. Torres to connect me with Doctors for Change, to be a panelist. I'm very excited. Myself and my other three sisters were survivors of severe form of labor trafficking, and everything started where I'm the oldest of my sister when I was 11 years old, and this happened in Mexico first. And some people think that it just happened to very poor people or uneducated people, but that side of my family, they were very wealthy and very high educated. We have what I said, not the weak link, but somebody in the family is not gonna have all the expectations. So my dad have a drug abuse, issue, and my mom developed a mental health issue. So we were, children that we were neglected by them because that situation. So that's how we know our trafficker, which was the mom of a friend at school. So, little by little, they groom us. I don't even know at this point, she did it with that intention in the beginning, but that's what happened. So she was so we grew up with her mostly, kind of. So she become like a mom figure to us, and she is a USA citizen. So when she moved here to the United States, she smuggled us here. So, but at the time we already was older than 18. But at the time, she already abused us or exploited us in Mexico. And little by little, because we were children when we start with her, she take us away from our family. I know it's a very complicated story, and I just want to let everybody know that every story is unique and every story have their own form. So not because I share my story, I want you to be, aware. You're never gonna encounter the same story of, the survivors. You may have some vulnerabilities and signs that are kind of the same, but every story is the same. So we moved here, and here in the United States was worse than in Mexico. She took away all of paperwork and start exploiting us. Why? If I tried to escape several times, yes, I did. But at the end of the day, when I did not have anyone to call, no paperwork, plus I did not understood anything about human trafficking, being a victim or anything like that. Plus she was very religious, so she not just abuses, physically. She beat us up. They make us eat things that were rotten or not eat at all. It was just like a totally mess. We didn't sleep well. We were very young. So as I grew up, we grew up, we didn't know what it was normal. That was the normal. For me right now, like as a survivor speaker, and talking to another survivors, we hate the term that in psychology they use, and I say it with all respect to all the professionals of trauma bond. We hate it because the word bond make us feel that we're gonna bond to that are traffickers or abusers for the rest of our lives. Even though we develop a lot of different diverse diseases, it can be mental, physical, you know, for the rest of our lives, making that a statement, you know, is just, to us, we don't accept it. For me, we were in survivor mode. It's the only way that you're gonna be able to survive, to disassociate where you're living through, you know, to go through that. Finally, one day after so many, I was in this situation for 19 years of my life. So finally, one day I escaped again, but this time I was just like, I was already dead, you know, I was already like an object. That's why sometimes I like feel very like a slave, you know, I did not have a say in a word, I didn't. So that time I just feel like it doesn't matter what happened to me, I didn't even care, you know, and, you know, I escaped. It took me 11 years to report the crime because I didn't know that I was a victim. I was undocumented still. So after I leave that place, I tried to survive, and believe me, miracles happened to me. So, you know, people randomly helped me. Other people also abused me because, you know, abuse was the normal in my life. So, you know, but, you know, one sign changed my life. I went to, that's why I think training and put up like you doctors or healthcares in your offices, you know, and I hope Dr. Torres can put the link for the website where you can print for free, you know, the posters that say some of the signs. I saw one sign I remember in a Walgreens, and they took it down. I never seen it again. That it says the signs. And I was with one of my other sisters that she escaped. Eventually, all of us escaped there, but the one that followed me after a little bit. And I saw the signs, and the only one that did not check with us was the sexual assault. That's the only one that did not, you know, check. And I was like, look at my sister and said, we are that. And it just like was a start in my brain. After that, you know, it happened some more years, and then I reached out to an organization, and that organization did not help human trafficking victims anymore, but they referred me to another one here in Dallas. So I reached out to them, and the whole process is being very hard, but I wanna, you know, is when I start saying like I need to speak out about my story, not just because of me, but for millions of people that are still being victims, and for survivors to encourage them, you know, and empower them to say that after you live through that horrible crime, you know, you can, if you survive, you can. It's difficult, it's hard, but you can try. You can regain your freedom, your rights, you know, create new dreams, because a lot of things are already gone forever, and you won't be able to regain that. And also to healthcare providers and social workers and everybody on the field that wanna, you know, help, you know, human trafficking victims and survivors, and to tell them that everything that you do is worth it, and encourage you to, you know, keep the training and keep empowering, and everything that you do, it counts. I know for experience that sometimes you don't hear a lot of maybe thank yous or appreciation words for the survivors of victims that you help, but sometimes it's really hard for us to process everything that we went through, and it's really hard for us to believe in people again. It takes a lot of time for the extreme abuse that we suffer, but you know, all the people that I encounter in my experience that is been helping me I always think of them in my head and in my heart. So thank you so much. And please feel free to ask me anything. If any question that you might have, don't think, oh, I'm gonna make her uncomfortable or anything. No, please ask me. If I feel I cannot answer the question, I will let you know that I don't feel comfortable or I'm not able to answer it, because the purpose for me for this is to help make awareness. Thank you.
All right, thank you so much. And we're gonna get started with the questions. I'm basically just gonna ask the question and then I'll turn off my camera. I'll let y'all just kind of talk amongst each other during the panel. And then once the conversation kind of dies down, I'll ask the next question. So our first question that we have here is, let me see if it'll open for me. Are there online resources to help patients experiencing labor trafficking learn more about their rights?
Do you want to take that? I was going to let Katie or Melissa take that because you were probably.
Sorry, I thought Rachel was actually going to jump in.
Yeah, well, I've seen a lot of resources through immigration attorneys' websites that they post and they translate. Like Texas Rio Grande Legal Aid has a great PDF on Know Your Rights. So every time that I want to kind of break things down for victims, survivors of labor trafficking, I direct them to those formatted PDFs from immigration attorneys. That is more local. So I think even Sage Justicia has a really great one there in Houston, and Lone Star Legal Aid as well. That's all I got.
Yeah, there's also different sectors that have organizations that address this. There's NDLON, the National Day Labor Organization, networking organization. I always confuse the ONDN. And their website is specific to day laborers. There's domestic workers national organizations. They have specific signs and rights for domestic workers, and similar organizations like that. On my presentation, the last screen that I shared with my contact information, that was actually a photo of us doing Know Your Rights trainings on labor sites. That's really important. We've really, and honestly, we offer trainings at the site, at the worker center. But like I had said, agriculture, domestic workers, and day laborers are the most at risk and the most difficult to get to our actual sites. So we started contacting one lady who was working in domestic servitude, and she invited friends over, and we had a Know Your Rights training at her, the apartment that she was at, or her daughter's apartment she was at over the weekend. We go to day labor job sites and do trainings there. So we share we share national resources through the Polaris site and the National Human Trafficking Hotline as well. I have to say a lot of those national sites aren't really directed at victims and survivors. Some of them might have a link of resources. So sometimes it might be best to look at the sectors and the sites that they have available.
Mm-hmm. Yeah, there's also United Against Human Trafficking on the website. I see a number of short video clips, but I think most of them are not directed towards the victims, but more like the helpers. But like I mentioned earlier, and Yuri also mentioned it too, the victims themselves may not realize that they are, victims of human trafficking. But it's the neighbors, the bystanders that can recognize some of the signs and connecting them with resources that is critical. The Polaris Project and these national organizations kind of help us recognize signs of victims of human trafficking to be able to help.
All right, thank you. And our next question is, what advice do you have for healthcare workers or providers in terms of documentation to support T visa advocacy / applications?
Sounds as it's directed at me. So for example, if I use the Filipino teachers case as one, we actually work with volunteers from the Physicians for Human Rights, have them provide a mental health evaluation to help validate the story experience of the clients to recounting their trafficking history. It's not, of course, the clinicians were not there when the trafficking had happened, but by observing their behavior and attitudes when they have the clinical consultation, they can, preliminarily diagnose, what may be some of the mental health issues that affect the person, and kind of validate their behavior fit those diagnoses. For example, they were consistent in telling what happened over course of a couple of meetings, and they provide the reports that we submit as part of the T-visa application. I don't think I've ever included the what do you call it, progress notes because I thought that was too personal and invasive, that USCIS have no right to know that. And very extensive affidavits from the client himself or herself, and also two people that know about the situation that the client has talked to about the experience to kind of validate the to provide credibility to the client's story. And a lot of the T-visa, a big part of the T-visa application is country conditions about the home country's effort of ranking in terms of preventing labor trafficking. The teachers were from Philippines, and at the time, Philippines was ranked like at probably, if not the lowest rung, second to the lowest rank in terms of protecting the people and preventing labor trafficking. And documentation about their for the Filipino teachers is an exceptionally educated group, so it was very easy to work with them. They all show up to the meeting with a portfolio of documentation, but a lot of the clients that we work with are domestic workers. They don't have anything, right? So a lot of it is really just the affidavit to tell the story, and that was important. And healthcare workers, social workers definitely has a role in supporting that application process.
All right, our next question says, over the past year, I've been learning more about the public charge rule and how many immigrants are afraid to seek help or use resources for fear of jeopardizing their resident status. In your experience, has fear of the public charge rule impacted patients' willingness to use public resources to disclose their situation? And if so, how do you counsel these patients or clients?
Katie, do you want? This has come up a couple of times clinically. Katie, do you have thoughts about resource utilization and public charge? Wait, you're on mute. Or maybe I just can't hear you.
I can't hear.
Got it. Okay, sorry. No, I'm not super familiar with public charge, so I don't think I'd be a good resource on this.
I've had some exposure to the public charge, but in helping victims who are afraid to. And the public charge is just an issue with immigration, that there's going to be a charge if they need any welfare help, any food stamps or Medicaid. So I've worked with a lot of victims, especially those who have the letter that permits them to get Medicaid, food stamps, and other support through health and human services. But it's that community fear that really just, they do not want anything to interfere with their immigration status, even though they're an exemption from the public charge. And I honor it as a caseworker in the past, and I find other resources like local food banks or healthcare providers that can assist without without medical insurance. But it is a difficult thing, especially if there's high need. But I think there could be ways around it with communities working with different immigrant populations.
Yeah, and public charge doesn't cover all the programs. I mean, it's specifically 8 federal programs. For example, Harris Health is not one of them. WIC is not one of them. And the children who are eligible, who are U.S. citizen eligible for the children CHIP program, doesn't affect the parent at all. So if the immigrant is not the recipient of even one of the 8 programs, it doesn't affect the immigration status. And I think when you encounter victims of human trafficking, crime victims, or domestic violence, you can tell them that they are exempted. The public charge rule doesn't apply to them. Refugees, it doesn't apply to them. Asylees, the public charge rule doesn't apply to them. And they have no reasonably short-term path to legal status. Don't worry about it because there's a 3-year look-back window. So if they are not ever going to have a path to legal status for another 5 years, be on public benefits now and then get off when the 3 years is going to kick in. And of course, I would hope that the new administration will get rid of the public charge rule, then we don't have to talk about it at all.
And to answer from a healthcare perspective, sometimes, can y'all hear me okay? Okay. Sometimes, even when we tell patients that, Harris Health is exempt, WIC is exempt, et cetera, because they don't know who to trust, they may still not believe their provider. And so sometimes we'll tell them that, and then we'll have other healthcare providers from the team tell them that, and they still will continue not to believe us. And so we'll sometimes bring in our risk management or some of our nonprofit partners to try to reinforce that truth. That doesn't always work, but what we can do is validate their concern and explain to them we understand. I've got a kid sneaking in. Sorry, close the door. Validate that fear and that concern, tell them that we hear them and understand what their concern is, or do anything that would sabotage their help. And so that doesn't always land well, but we just have to do our best and understand where the patient's coming from with issues of trust and because healthcare providers, all members of the healthcare team are considered sort of authoritarian and paternalistic because there is a power discontrol with areas of things like knowledge over their healthcare recommendations. And so that power differential is something that can make people who are vulnerable feel like they can't always trust their providers, even when our best interests are there.
I want to add to what Zenobia said. The majority of undocumented immigrants that are in the U.S. have actually been here much longer than whatever available pathway to citizenship there is, like over 10 to 15 years. So whatever, they haven't had access to a pathway to citizenship for that long. So there is some misunderstanding, but the larger issue of what the public charge is, there's some misunderstanding. But the larger issue that plays into that is mistrust of these systems in general. So, mistrust of the system and reporting them as a public charger, that process. But overall, even knowing that they don't have a pathway to citizenship is not accessing these resources, one, by cost, but not trusting the institutions.
I would also add, working with your partners is very important. So if you have a victim and they are in the stage of working with an immigration attorney, definitely call the immigration attorney, let them know the fear, and just refer them back to them so that they can answer all those questions and demystify the public charge and what it really means.
Yeah.
All right, thank you. That was a great discussion right there. Our next question is specifically directed to Yuri. It asks, when you were being trafficked, what could a healthcare provider asked or told you that would have made you more comfortable telling them what was happening to you? And what are a few things you think doctors could do better in reaching out to human trafficking victims?
Thank you. Well, most of human trafficking, even sexual or labor traffickings, we don't go a lot to doctors because you need to be like really, really, really sick to take you over there. But mostly, somebody's gonna be with you. Someone is gonna translate for you. Even though you're an adult. So it's very something is gonna look awkward. Sometimes in the first encounter you won't be able to know. But in my experience, I think if the few times that I went to the doctor when I was being trafficked, if I saw a sign, a poster that said that, some of the signs, I will escape sooner. I will reach out for help, because one of the things that they have is a lot of fear, and a lot of fear of, any kind of police, or no, you're so freaked out. Like it's very long to explain you how they brainwash your mind, but it is for people that is always being free. It's really difficult to understand, but that will help someone, to have. Also, if you see something, say something. Even though if you suspect something, you don't need to be certain. You can report it. And one day I went by myself to the doctor. They gave me money because I was really, really sick. And it's like I was not myself. Now that I think in myself to the back, it was just like surviving mode. I was not even thinking. But maybe if someone asked me questions like, are you okay? Do you have family here? Maybe, I will open up. I don't know. But what I know now is like right now as a survivor, I decide by myself with the doctors that I go. I just one day said, you know what? I need to tell them that I'm a survivor of human trafficking. I have the good luck that both of my doctors, well, the first one, she just said, I'm so sorry that you went through that. I just like the empathy to me was huge. She, and she just treated me with dignity, with, like everybody else. We don't like to be treated like, oh, like pity, like, one thing is just sympathy and another one to be empathy. Like, okay, she really was honest to saying, I'm sorry. And she, at one moment, I need to go to referral to another doctor. And I also told them, but I have another doctor that I told her, because she's not trained, she just looked at me like on disbelief. And I felt like she felt insecure with me in the room. Like maybe I will attack her, or I don't know, because I don't know what is her opinion of human trafficking. I just say human trafficking, I don't say labor or sexual. So she didn't know what to do, and she never rescheduled me again. And I knew she was so scared of just me saying I'm a survivor of human trafficking, So if you really like educate yourself, that I want to tell the doctors, keep educating yourself and tell all other health providers, put posters in your offices, in the bathroom, and if you see, as you get educated about human trafficking, you will start seeing, some signs. And if somebody is translating for another person, try to put them in a separate room at one point and ask them different questions. Are you okay? Bring somebody from the office that maybe speak the other language, that person by themselves. I don't know if that answered your question or no.
Well, I'm following up on that real quick. We have another question for you, which is kind of similar to what you were speaking about, which says, are there other terms that healthcare providers should avoid using with our patients? For instance, should we be open in telling a patient that they screen positive for trafficking? Or could this be potentially alarming or distressing for a patient to hear if they don't identify as a victim of trafficking?
Well, for some of them, if they're already like, it took me a process to understand, that I was a victim of human trafficking. And it was really hard for me to, it was a process. If a person is being trafficked, most of them, you don't even know. You don't even know. It's like you have a disease and you don't even know you have a disease, right? Until you go to the doctor and they give you the diagnosis. Like, I have a headache, my stomach, but you don't even know. So with human traffic victims, it's kind of the same. Some of them, they know, but if you feel like, no, maybe like labor trafficking, human trafficking, but under that, like, you get paid for what you work for. It's somebody, holding you against your will, and all those signs, it makes me like, oh yes, oh yes, oh yes, oh no, oh yes. So that may help, the health providers, to identify a victim of human trafficking. That makes sense? Because maybe some of them, they don't know they're human trafficking victims. They don't know yet. They don't have that label on them, that definition. But maybe you didn't get paid, for the work that you do. Somebody's holding your identifications? Are you free to make phone calls? Do you live with family, or do you have somebody else related to you? Do you have family support? You can go and to whatever place whenever you want? Those are the things that we cannot do at all. Do you take your own decisions? Do you have the right? We didn't have any rights, so I don't know if that will make sense. But do you, could you do you need transportation? Do you need somebody to translate for you or something like that? Maybe those things, it will help you, identify a victim.
Yuri, can I add something? ¿Puedo agregar algo?
Sí, claro.
We've done studies in at-risk populations regarding this, and even before that, I just want to say in other issues of violence, you don't ask someone in an IPV situation, are you a victim of domestic violence? Is this your perpetrator? You ask, have you been hit? Is your money being kept from you? You ask about the signs and what puts them at risk versus the title that you're identifying them with. It's the same thing. In studies that we've done with at-risk populations, when I've identified the majority of unidentified or previously unidentified victims and survivors, I didn't use the word trafficking in any of the discussions. I asked them about their experience. I asked them if they felt that they didn't have a choice in, doing what they needed to survive. And some of them would ask me, what do you mean by work? What do you mean by labor? And I would tell them, what do you mean by this? Did you feel you had to do this in order to get something you needed to survive in exchange? And then everything came out. A lot of these, in the study in particular that I'm thinking about is kids, but I've done this with adults as well. A lot of them don't have that identity, especially when it comes to labor. They feel it was just exploitive practices. So using the word trafficking really is kind of useless in the situation unless it's done for the purpose of actually diagnosing or treatment. In one study that we did of a 50-minute survey, I used the word trafficking twice, and it was specifically to ask them, while you were in the situation, did you ever come across law enforcement? Did they ask if you were trafficked? While you were in the situation, did you ever come across healthcare providers? Did they ask if you were trafficked? And that's because law enforcement healthcare has used these terms specifically when they're addressing potential survivors. That's the only time I used the word trafficking, to see if they had heard that before. The rest of the conversation was telling me about the exploitation and the trafficking. Second, to add to that, particularly from my experience with Latinos as a Latina and speaking Spanish, and I've heard this in a lot of other immigrant populations, the term trafficking doesn't translate to what it means in the other languages that they say. Specifically in Spanish, tráfico is understood as something else and definitely not towards labor. So just speaking about their experience, asking them if they felt, those risks and indicators of force, fraud, and coercion, not using those words specifically, but, talking about it to gather that is what helps.
Yeah, I learned all this language after, you know, I reported, I went through the case. And like, actually when they were saying that, you know, smuggling and trafficking, and I'm like, what's that? I just know somebody abused me and I know just the signs, but all these languages, I learned it, you know, and I use it now to advocate. But, you know, if I put myself as the victim, as other victims, we want to say, oh yeah, I am. No, it's like Melissa said. Thank you.
Well, thank you all so much. I think that we've actually run out of time at this point. I know that I have more questions that I would love to ask, but I also want to respect all of your times. So I think I'm going to go ahead and wrap up the panel discussion at this point. I want to thank all of you for participating, especially our speakers who were gracious enough to speak to everybody about their experience and their knowledge in this very important subject. I want to give special thanks to our speakers as well for helping us recruit some of our panelists, which was very helpful. Special thanks as well to the Executive Director of Doctors for Change, Ariana, for helping out with the organization, as well as Jorge Cruz, our Program Director. So yes, thank you so much. And thank you to everybody who tuned in and sent our questions, because I thought that that was a very robust discussion that we were able to have on this panel. So thank you so much.
Thank you.
Thank you.